Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Sheylan Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Today, I'm pleased to announce that we have Dr. Lea Famularcano joining us. Dr. Famularcano trained at the University of Santo Tomas Medical. She went on to then complete her family medicine residency at WVU Charleston. One of her special interests includes obesity medicine, as she serves as the medical director of the CAMC Weight Loss Center. She spends much of her time working amongst a team while also seeing patients and teaching and mentoring residents. Thank you so much for taking time out of your busy schedule to come and be with us.
Absolutely. Thank you for having me.
So,
good to meet you.
Yeah. So, Dr. Famularcano, when you're not practicing medicine and you're just in your normal day-to-day life, what do you like to do outside of?
Okay. So, I'm first and foremost a mom.
Oh my gosh.
I have an 18-year-old. He just graduated from high school, and now
congratulations.
Getting ready to set him up for college. So currently, that's what I'm preoccupied with, as far as getting him, set up to do that. And he's leaving. He's going to Colorado. So that's quite an adventure for the whole.
A big journey. It's going to be nice. I guarantee I know one of your vacation spots coming up in the near future.
Yes. Yeah, and so other interests are, we have real estate interest. We have a short-term rental that me and my husband manage. So that is one of the non-medical things that we do. And then I also am a health and wellness coach. So I have a little side gig where I help my patients, but clients achieve their optimum health. So that I do that on the side.
That's awesome. So what does that kind of look like for you, like in terms of working with not necessarily patients but clients?
So it is a different flavor to it. It could be interspersed some as far as lifestyle modification, lifestyle coaching, but it gets really more into a lot of motivational interviewing, and then a lot of getting into the nuance of their lifestyle and what are their obstacles. Mm-hmm. So there is some overlap, but with my coaching clients, I get to have more frequent contact with them because I meet with them weekly, and a very, very personalized approach to health and wellness. And I like it. I really enjoy it as well.
I was going to say that is such a nice way that you kind of put that into perspective, kind of working with people not necessarily in the clinic but outside of the clinic in their normal day-to-day lives, and like you said, an individualized plan. Mm-hmm. So that kind of leads us into our first segue, which is our case number one. Okay. So we have a patient here that we just kind of want you to run through us. Miss Jones, she's a 38-year-old female who presents to your clinic to establish care. She has a BMI of 32, but no significant past medical history aside from mild anxiety. She's attempted multiple weight loss strategies, including intermittent fasting and high-intensity interval training, but has only managed to lose and regain the same 5 to 7 pounds over the last 2 years. She is concerned about her long-term weight trajectory and asks whether medications could help her finally achieve sustainable weight loss. So, Dr. Famularcano, whenever you have a patient like this that kind of comes to you, what's your initial approach really in terms of evaluation?
So when a patient comes through into our program at the CAMC Weight Loss Center, we do a complete evaluation. We have an intake that we do for them. First of all, we, usual history of the weight. When did it start? Did it start in childhood? Did it start, in their puberty or, older?
What does
the patterns like that.
What does a complete intake look like? Do you guys have like a form that they fill out,
Yes.
or?
So there's a form that they fill out, and that contains these questions: what was the history of the weight? What was the pattern of weight gain? Was it rapid? Is it fluctuating throughout the years? So we get more information in that way. It is important as well to know the onset, right? So if it is prior to age 5, then we think about genetic predisposition or family or genetic
A genetic component
predisposition for the obesity. And then if it's more pubertal onset, then we think about hormonal, like PCOS and things like that. And then, like over time in their 30s, 40s, so that's more than likely associated with metabolic issues or lifestyle, lifestyle choices. So then we glean into that sources or causes of the obesity as we obtain that history. Sometimes it could be some underlying events, life events, like we see a lot of patients who come in and they said, well, I gained all this weight when I was going through a divorce, or I gained all this weight when we moved from one area to another, or I gained weight when I moved to a sedentary job. So like really a lot of information that we could gather on the get-go. Then again, we ask about previous attempts, right? Previous attempts of weight loss and what had been most helpful for them. And so if something had worked for them, then we kind of like go towards that theme. Like for our patient here, she's doing intermittent fasting, she's doing high intensity interval training, so looking into like what's her comfort level and like how comfortable she is with that plan. And then, so more importantly, I ask about their strong reasons why they want to lose weight, their motivation. For our patient here, she has no comorbidity.
No comorbidities, absolutely.
And her BMI is of 32. So, because sometimes with this type of patients, our goal when helping them to lose weight is health.
Yeah,
right?
Absolutely.
So if they have no comorbidities, they are comfortable in their bodies, and they have no chronic pain or anything like that, then we might be able to say that they are healthy at their weight. So maybe we don't necessarily need to help them lose any more weight, but more of like maintain function or maintain their current level of activity. So that would be maybe primarily my approach for this patient. And then you did say that they are concerned about long-term weight trajectory. So like I said, maybe we could just maintain them at this place where they're at, maintain their activity, and then go from there.
Absolutely. When you're mentioning like being healthy at this weight, what are some things that would kind of be like a red flag for you in terms of like looking at long-term ramifications, like diabetes, or what would you be looking for?
Yes, absolutely. So that is a very good question. And one thing that I also look beyond is the BMI. So of course BMI is like the easiest way that we could determine obesity, right? We have our classification, BMI between 25 to 29 is someone who's overweight, and then BMI 31 to 35 would be class 1 obesity. 35 and above is class 2, and then 40 and above would be your class 3 obesity or severe obesity. So, but then, like our patient here, she's very healthy, but her BMI is 32. So just looking at the BMI, she would classify in the class 1 obesity. However, though, we have other measures of obesity. In this case, we want to try to see if their waist circumference meet diagnosis for obesity as well. So any So for women, we'll determine what her waist circumference is. If it's 35 and below, then that does not meet the criteria for obesity. So, so several other factors like that. We look.
That's interesting. I did not know that at all.
The waist to hip ratio.
Yeah.
The reason why we're interested in abdominal measurement too is, as you know, visceral fat is associated with metabolic disorders.
Absolutely.
So then that's why we're concerned about it.
So it sounds like you guys do a really comprehensive evaluation. Like when we're sending patients to you, that's very reassuring. What does your team look like? So there's you, and then I'm hearing things about like during the intake, if there's like a certain life-triggering event, let's say this patient fills out the questionnaire and you identify some depression. Do you guys have a means of helping this patient get help?
Yes, absolutely. Very good question. So our intake does the screen for depression, anxiety. We utilize tools like PHQ-9, the GAD-7, and then we also screen for binge eating disorders. And then once we do find that they, like they are meeting criteria for these, we have a psychologist. We have a psychologist in our clinic, and if it's strongly that these clinical diagnoses like depression or anxiety and the binge eating disorder are strongly affecting their weight, then we refer them to our psychologist for that for that further testing. And you did mention who are the other members of our team. So like just in this intake, right? Like, so I'm just gonna walk you through like how it happens.
Absolutely.
Patient walks in the door. We have our front desk office. They give them the form and fill out that intake. Our medical assistants are trained in getting these measurements. As I have told you, we measure the neck circumference. We measure waist and hip measurements. We also have a body composition scale. So like, I don't know if I mentioned that to you.
No. Can you tell me more about that? That's exciting.
So we do have a body composition scale that tells us their basal metabolic rate. It tells us their fat percent, okay, at a baseline, and then what is their water weight, total body weight, total body water weight, and what's the skeletal muscle mass.
Oh my gosh.
And so like on that first visit and every visit, we are able to track that. And the reason why that's important to us as obesity medicine practitioners is that because the number on the scale does not tell the whole story.
Absolutely.
Right? So we're able to, like, because like a lot of the times our patients are frustrated because the scale might not be moving, right? So they're like, oh, I did lose weight, but then we're able to do these measurements for them, and we're like see the things that you were doing contributed to that fat percent getting lower, or like your waist circumference actually had gotten smaller. So so those little wins like that are not associated with the number on the scale, that we're able to give to them and give them a little bit of encouragement to keep going.
That's really good. That's awesome. Yeah. So in terms of, so you see this patient and this, we're kind of thinking that maybe she's healthy at her weight. Let's say that she has no comorbidities like diabetes, no familial hyperlipidemia, she's not having chest pain, but she says, Dr. Famularcano, I am very much wanting to try pharmacological therapy. Is there an option for this patient without comorbidities?
So absolutely. So she would meet, if we're just talking about criteria for obesity treatment, then she would meet these criteria, right? So for oral medications like your Casemia, Contrave, it's for BMI 27 and above with comorbidities are the criteria for treatment, and then for BMI 30 and above, regardless of comorbidities. So she would be meeting that criteria because her BMI is 32, and if she does desire oral or any medication, either oral or the injectables or the GLP-1, then she would be meeting that, and then we would definitely try it out depending on her goals.
Absolutely. How do you approach like which medication that you're going to use in each patient? Like versus a GLP-1 versus something like phentermine or Qsymia? Do you have like a typical?
Yeah, very, very good question. On that first visit, there is the beauty of obesity medicine, I think, is that we have this set of FDA-approved medications, and like we could actually present them with the option of like, okay, so this is what we can offer you, and then really discussing to them. We try to tailor fit it
Absolutely.
to the patient. Like say if they might have, if we may see any evidence of insulin resistance,
Absolutely.
or if there might be history of PCOS, then metformin might be a good first step just to improve their insulin resistance. Keeping in mind that metformin really is not a weight loss medication. It's not indicated for weight loss. But as we are trying to help them lose weight and they've tried everything, the insulin resistance might actually be fighting it. Right, so by correcting some of that insulin resistance, then they might be able to get past what their weight is.
That's a great. So I'm hearing like a very individualized approach.
Very individualized approach.
So like this patient with anxiety, like phentermine may or may not be like the best option for her.
Yeah, you are correct, because of course it is a stimulant, and it can increase palpitations and can increase anxiety. So it might not be our best option for this patient. And again, like if they might be more, how would you say, there are other options like Contrave, which is bupropion and naltrexone combination. It is FDA approved for weight management. This medication I usually would offer for my patients who might have a lot of stress eating.
Okay.
Stress eating, they have emotional eating. So those patients that would present with like, when I had depression, or like when I had my divorce with my husband, I just gained a lot of weight because I just stress ate throughout the day. So this might be the best candidate for something like Contrave.
Absolutely. So that pretty much wraps us up with case number 1. I'm hearing that whenever I send a patient to the weight loss center, they're getting a comprehensive evaluation. And then treatment is really going to be on an individualized approach. We're looking at comorbidities, like things like insulin resistance or type 2 diabetes, and we kind of tailor our therapy to their underlying comorbidities.
Yes, that's what we would like to do, and they're just not coming in just for weight, but really, as you have said, a comprehensive evaluation and really looking into underlying issues as well.
Well, thank you so much.
For decades, we have performed the most complex heart and vascular procedures using groundbreaking technology and minimally invasive techniques with a team of more than 60 specialists. Don't trust your heart to just any hospital. CAMC is the region's #1 heart and vascular center for a reason.
Scheduling your primary care visit is just a click away. CAMC Primary Care and the CAMC Family Medicine Center now offer online scheduling. Book your appointments easily from home or on the go at your convenience. To schedule your appointment, visit camc.org/primarycare.
So Mrs. Jones is very appreciative of the care you provided her, and she actually referred a friend to you. I'm not sure if you knew that. Mr. Smith, he's a 45-year-old male. His story is a little bit different. He has a BMI of 37 and a past medical history significant for hypertension, hyperlipidemia, and prediabetes. And he is actually presenting to your clinic to establish care. His most recent A1C is 5.8. He reports that trying low-carb diets in the past initially provided some success, but he found them difficult to sustain due to work travel and social events. He currently takes lisinopril and atorvastatin, but has not been able to tolerate metformin due to GI distress. He's inquiring about potential medications that may help with weight loss. So very similar to Mrs. Jones, just kind of just picking your brain. How do you approach pharmacological therapy with a patient like Mr. Smith?
Okay, so first and foremost, I want to try to approach it stepwise as well, like what are the lifestyle approach that we could use first. And of course, I don't take it at face value as far as what they tell me, like I don't have time. I don't, not necessarily not accept it, but of course, trying to find ways throughout there. Maybe find time throughout their day, really looking into a more thorough evaluation of their time, like a nutrition audit.
Absolutely.
Or a physical activity audit, and like how is their day structured from day to day, on the weekdays, on the weekends, and we might be able to find a little bit room for improvement, for activity or anything like that. So I do try to meet them where they're at and see what might be possible as far as lifestyle modification. And oftentimes, like it's not black and white. And I guess my skill as a life coach or like a health and wellness coach comes into play here when I might be able to do a lot more motivational interviewing and finding a wiggle room that they can make healthy decisions.
Absolutely.
Like that, yes.
When patients are presenting to you and they're saying, I've tried this low carb diet, it doesn't really work. How do you approach like dietary advice to patients? Is it kind of meeting them where they're at?
Yeah, so like I said, so he's done low carb. We want to try to tease that out. Like what is low carb, right? So how low is low carb, right? So is it below 50 grams of carb a day? So in most people, that is not sustainable, right? So and they might be able to do it for like a couple weeks, a week or a month or maybe 12 weeks, if they're like truly a motivated person. But eventually, life happens,
It does.
Vacation happens, and
I've been there.
right? And again, like I said, I mean, it might not have been sustainable at the time. It might have worked initially, but because it's not it doesn't fit their lifestyle, then they go back into.
So trying to find something that more or less fits each individual person.
So like again, like we tease it out, like so maybe we could do like low carb, because low carb is anything 150 grams and below, really. So we'll try to find a good medium where it's still low carb, but like where are the carbs coming from? It might be low carb, but it's coming from sources that are not like whole foods or like from your vegetables or fruits. So we want to tease that out.
I had an interesting story, and you may or may not remember this patient, but this special patient of mine that I'd sent to you is a truck driver, and you had encouraged him at each stop to get out and to try walking, and that was a way that you had incorporated exercise. So again, just kind of going back to what you said, meeting the patient where they're at.
Yes.
I thought that was really nice.
Thank you. Yes. So again, and we won't be able to find that out. Like we really want to try to get to know our patients in that, like really, really almost intimate way of like, how can we find that time? And so this little 10 minute during their breaks can definitely
make a difference.
Improve, like glycemic control, as like anytime that you move your body can improve your blood sugars, and then of course just overall well-being. That can be helped as well with that. Oh, thank you. I think I might remember that patient actually.
So we've got Mr. Smith. So we've done our lifestyle modifications. He says, you know what? I'm going to start implementing these. I'm so thankful for that advice. And then he says, in terms of medication, Dr. Famularcano, I don't know if it's reasonable, but he says, I've tried metformin in the past and it didn't really help. I am pre-diabetic. My A1C is right around 5.8. Is there anything that we could offer this gentleman?
Absolutely. There are definitely a lot of options. So I would first ask if he's tried metformin, if it was the regular formulation or extended release. Sometimes the extended release can be better tolerated with GI side effects. So sometimes I would try that. And if definitely not tolerated, then absolutely GLP-1s might actually be a good option, and he does meet criteria for that. And he BMI above 30, without comorbidities. GLP-1s like are semaglutide, Wegovy, or tirzepatide, Zepbound, right?
Yeah.
So one other daily GLP-1 out there as well is liraglutide or Victoza. So those are the GLP-1 options. And
Do you have a favorite?
Definitely, it's still individialized, right?
Absolutely.
Victoza, for whenever it came out in, 15 years ago or so, it was the only one, indicated for weight management. And so we make do with what it can provide, but it did provide a lot of side effects there. It's also daily, and so we worry about compliance.
Absolutely.
The beauty about these weekly injections now that we have with semaglutide and tirzepatide is they're more compliant with it once a week. Pick a day and then do that every week.
So semaglutide and tirzepatide are weekly, and then liraglutide is going to be a daily injection. And you mentioned side effects. What are patients typically? Are there severe things that you look out for versus like some minor things? What do patients typically complain of?
So I guess across the board with GLP-1s, we look at GI side effects. They might have some nausea with it in the beginning as they're getting used to the injections. A lot of the times I hear a lot of complaints of constipation. Yeah.
Really?
So constipation.
Yeah.
I guess it just kind of goes with the territory just because it slows
down the gut.
Gastric emptying, and so it kind of comes with that mechanism of action, the constipation. It sometimes gets better, and then patients do live with it with taking some stool softeners, things like that.
That's a good trick. If somebody comes to me and they're on a GLP-1, they say, doc, I'm just really not going like I used to. Maybe consider adding on a little Miralax or something like that.
Yes. And then also, of course, you want to try to look into if they're drinking lots of water, and then also do they have enough fiber intake. So we want to try to be
mindful of that. Yeah. Are there any contraindications where you're like, you are absolutely not getting a GLP-1?
Yeah, very, very good question. We definitely counsel that on the get-go. So if patients may have history of pancreatitis, idiopathic pancreatitis.
Yeah, absolutely.
So if there is no known cause for their pancreatitis, then they might not be the best candidate for this medication. If it is like, if we knew the cause of the pancreatitis, like
gallstones or
gallstone, so then we might be able to proceed with caution with that. And I've done that actually. So being able to have that conversation with the patient of like, hey, there is risk of pancreatitis, but we know that yours was from the
gallstone. Yeah.
So we should be able to proceed. Just let me know if you have any issues with it early on, like if you have having a lot of abdominal pain or vomiting and things like that. So, and then the other contraindication is family history of medullary thyroid cancer.
Oh, okay.
So those are the things that you want to try to tease out. So not all thyroid cancer. So if they presented with history of papillary,
absolutely,
cancer, then that's okay to proceed. So.
So that's good. Just like a very thorough it's not always just cut and dry. On patients who can get GLP-1s is what I'm hearing. A thorough history.
Absolutely. Just because, it's being thrown around, like in social media,
Uh-huh.
and like it's just like so very popular, and
They're good drugs.
they're very good.
Very good drugs.
And so like a lot of patients, both patients and maybe medical practitioners are cavalier about it, just because everyone's doing it, right? But we want to try to do our own due diligence as far as teasing out who might be the best candidate for these medications.
Yeah. So, wow. Mr. Smith is extremely pleased with your recommendations today. Sounds like you've counseled him on lifestyle. You've encouraged him to start incorporating some exercise into his daily routine. And then you looked at pharmacological therapy with maybe something like a GLP-1. And he's go ahead. No.
Yeah, one of the things which we encounter quite a bit is, and I don't know if we can talk about it, but like insurance coverage is the biggest
yes.
thing. Yeah, like we might have the best intention to help our patients, but insurance coverage can pose a lot of barriers for us.
Yeah. How do you?
You might have known.
Yeah, we very much deal with that, and that brings me to like another thing that I love is the 340B program here. I don't know if you guys use that, but we certainly do in the family medicine clinic. I will have some patients who their insurance may not be able to cover it, but we still do have Victoza on the 340B formulary.
And I don't know if you were aware, but there's a shortage of that too, or they're not getting resupplied, or
It has been on backup. I've had a few a back order.
So both liraglutide, which is Victoza, and so
Zenotide, I believe. Well, I believe that.
exenatide,
yeah.
Byetta is also there. Although there's no indication for
Weight management.
for Byetta, we do use it just because it's a GLP-1 too, and some people have been successful.
That's
losing
good.
weight with
Yeah.
it too, but some of my patients have tolerated it, but again, tolerability could be a problem with exenatide.
Yeah, we have had that. Yeah. So we have our last patient, a 55-year-old female who's presenting with a BMI 44. She presents for a weight management consultation. She has a history of type 2 diabetes. Her A1C was 8.2%. History of hypertension and osteoarthritis that limits her mobility. She has been referred for bariatric surgery, but is hesitant about undergoing an invasive procedure. She asked if medications could help her lose enough weight to improve her mobility and health outcomes with surgery. So really just this patient walks into your clinic. She's BMI 44. She says, Dr. Famularcano, I'm really not able to exercise as much because my knees hurt. And she asks you about pharmacological therapy. What's kind of your approach with a patient like this?
Yes, this is a very good case, of course. So in helping our patients decide between pharmacologic and bariatric treatment, sometimes we use both. But in this particular case, first I trying to meet the patient in their thought process and see what might be behind the hesitation for surgery. All right. If I can, I try to walk them through the process, explaining to them the pros and cons of bariatric surgery versus lifestyle and oral medications, and how much weight they are expecting to lose, or how much they're expecting to lose, and also what are the expected weight loss with the therapies that we're going to be providing. And so lifestyle modification typically is about 5 to 10%. Without any medication, then they could expect between 5 to 10%.
That's quite a bit.
It's quite a bit.
Absolutely.
And when we're counseling our patients in the primary care setting, all we need is 5 to 10% to provide value, or to provide improvement in their risk factors for diabetes, hypertension, or other future risk factors for cardiovascular disease, preventing heart attack and stroke. So we just need about just 5 to 10%, right? And then I also give them expectations what they could expect to lose with oral medications. So with some of the oral medications that we do that we could use, between 10 to 15 could be what typical result that we could expect. Some, of course, some are less. Some could lose more. So, and then the GLP-1s, they're pretty powerful, and they can provide 15 up. So with semaglutide, between 13 to 15%. Okay, weight loss we can.
That's wow.
With their trials, and then with tirzepatide, it's 22%, and then their long-term results have been up to 26%.
Oh my gosh!
So
wow.
It's pretty good, right?
That
so
is.
This patient could definitely benefit with oral medication, but also I wanna talk to them about bariatric surgery, just because it is not just a weight loss surgery, but also a metabolic. Like it's a metabolic surgery, and with someone who has, in case of our patient, she has an A1C of 8.2, and therefore it is not in the best control, right? She could potentially benefit both from GLP-1 therapy, but the surgery as well, just because of that metabolic effect that I was talking about. We can expect between 30 to 40% typical result for our bariatric surgery patients.
Wow.
And then we actually are able to put them in diabetes remission for as good as 5 years, and then sometimes as good as 10 years.
That's amazing.
So it is amazing. And so, we want to try to give them these, these results, or like this expected result. As we know about diabetes, it is a chronic medical condition, and as a patient is going from diagnosis of prediabetes up to when, like 10 years, 20 years into the disease process, it's like they develop end organ
damage. Yeah.
End organ damage.
Absolutely.
And so if we might be able to
save them 5 to 10 years of that.
Years of end
End organ damage.
And that's the typical conversation that I have with these patients. Like, if we can halt some of the end organ damage for 5 to 10 years with bariatric surgery,
Yeah,
that's
from
the benefit.
from a patient perspective, like, I think I would be sold if you told me that.
Right?
Yeah, you're telling me that essentially I'm getting 10 years of less damage on my heart and my kidneys. Blood vessels. I mean, that is, wow, I didn't know that, so thank you for that.
Yeah, absolutely. Like retinopathy. So just so much benefit as well. And then, of course, it's very personalized. Someone have told me, like, they truly are apprehensive of any type of surgery, just because the last surgery they've had some complications, like anesthesia wise, and they had like maybe reaction, or they were hard to wake up after surgery. Just this little concerns that not little, but like you want to try to listen to them, meet them where they're at, of like, why are they concerned about, or why are they hesitant? So we want to try to be able to find that out, and go from there. She still would be a good candidate for GLP-1, absolutely. 'Cause like we could still get a lot of benefit for GLP-1 therapy, improving her glycemic control, and still provide all those cardiovascular benefits. Especially with semaglutide, as you know, providing cardiovascular benefit for someone who's had a previous heart attack or a previous stroke. So those are the indications for semaglutide.
Wow.
Cardiovascular indication. Yeah.
That's so good. So I'm hearing that when you get the apprehensive patient who says, I'm just not wanting to do surgery, you kind of just educate a little bit about what you can offer in terms of pharmacological therapy. It sounds like you've got a lot of good tools in your tool belt, whether it be phentermine or a GLP-1, and again the different GLP-1s providing different percentages of weight loss from the BMI, which I did not know. Sounds like tirzepatide gives you around 26%, which is
26%.
wow.
Their long-term data of 18 to 24 months have provided up to 26%, and we're seeing that too.
That's amazing.
We are seeing that. We do have a population of patients that have been on these therapy for more than 18 months. So we're seeing that they are achieving this even more. Actually, even more. So it is such a helpful medication, a very, very helpful tool for really not just obesity management, but for all of us, managing chronic disease.
Absolutely.
Yeah.
And then you kind of educate them too about like bariatric surgery, telling them what they can benefit from that, and then allowing the patient to kind of make their own decision.
Informed decision, yes.
That's very good.
So we want to be able to present them with everything. So like, this is what we can expect with the medications. This is what we can expect with bariatric surgery, and then this is what we can expect if we don't do anything about it. So like really being able to give them the option and really look like one tool that I also use is projecting 5 years, 10 years from now. What do you see? Like what does your health look like 10 years from now, right? So,
forward thinking, making them think
Yes.
about the future.
Yeah.
Wow, that's a good, I never thought of that.
Yeah, so
Kind of brings it into perspective
bring it
a
into
little bit.
perspective, definitely, especially for someone with our patient here who's already have several comorbidities.
Yeah,
She has
55, A1C of 8.2.
hypertension, osteoarthritis.
We all have these patients.
We
you
all
know?
have these patients, like they are our everyday patients.
Absolutely.
Yeah.
This
so-
is Appalachia. Yeah. How are you counseling patients? This is something that I've always wondered about as a family physician. When we send patients to you and they're undergoing this substantial weight loss, what are you doing in terms of like dietary recommendations about like protein intake? Do you guys have a certain goal that you want?
Yes, absolutely. So we do their nutrition intake.
Okay.
See what they are, what they're eating on a regular basis. We don't shame them.
Yeah,
right?
absolutely.
We don't want to do that. And so, like, we just do an inventory. And my approach myself is like gentle changes, right? So, if they might say, I drink 2 liters of soda a day. So
Yeah. So maybe trying to reduce that to 1 liter.
Yeah. So like really educating them on, hey, you know what? Our body's only able to process about 26 grams of added sugar. If you're a female, then 26 grams of
I did not know that. Wow.
Yeah. So and then we can say, let's just take a look, and I pull it up online. Okay, so what is your favorite drink? So it could be like Mountain Dew, right? So like I say one 12 or 20 ounce bottle of Mountain Dew. Off the top of my head, it's not exact. Don't quote me. But it's probably 74.
That would be impressive.
Yeah,
Wow.
so 74 grams
That's
of
a lot of
added
sugar.
It is a lot of sugar.
Yeah.
And if your body's only able to process, like 26 grams, the rest of it, it's scrambling to store it someplace else, like in your liver, in the visceral fat, like a subcutaneous storage and all that. So, yeah. So
That would make me think differently about having that Mountain Dew.
Yeah. Even that is very sobering to them, and like, and just providing them with information and just giving them the power, like the knowledge, and also the ownership of their decisions.
Absolutely.
And not necessarily tell them you have to stop soda,
Yeah.
But
Easier said than done for some. Yeah.
Yeah. So we say, okay, so like this is what's going on, this is how much, and this is what your body can process. So maybe, come from that perspective, like what would you like to do about it?
Some motivational interviewing
Yes.
is what I'm hearing.
Yeah.
Wow.
Yeah.
So it sounds like when we send patients to you, they're getting a lot of education.
We try to, of course. And then I think I may have failed to mention, we do have the support of our dietitians as well. And so we have 2 dietitians in our office, and then we also have one in one of our hubs.
Yeah.
In I'm blanking. Lewisburg.
Lewisburg.
At the Lewisburg office, we do have our dietitians. She helps out as well, very, very significantly, to support our patients.
That's amazing. So patients have the ability to see dietary, psychology, yourself, bariatric surgery, if that were to be a potential
if that
option.
might be a possible option for them, then we transition them into the surgical track. And one other support staff that we have is an exercise physiologist. So at our facility, we have a gym.
Oh,
Okay,
wow.
and it is
Really?
a well-equipped gym with exercise machines and cardio machines. So it is available to all our patients who come through our office if they may choose to join our gym, and to be able to utilize the expertise of our exercise physiologist. They are welcome to.
That's amazing. So so they meet with the exercise physiologist. Does he just kind of educate about like resistance training or cardiovascular exercise? Does he give them a routine or?
So in the beginning, it would be more of like initial evaluation.
Yeah. Because I'm sure each patient has different needs or
Yes.
maybe mobility issues
Yeah,
or.
mobility issues, especially for our patient here who has osteoarthritis. So then, again, being very cognizant of their limitations and tailoring the recommendations for that patient. And if they do want to come back for like on a regular basis with a routine, then he would tailor that for them as well.
That's amazing. Wow.
Yeah.
So it sounds like the Weight Loss Center has so many good resources for our residents here in Kanawha County and for Charleston. So that's amazing.
Yes.
You're really trying to help us not only lose weight, but just be healthy.
Absolutely.
And that looks different for each different patient, because I presented 3 different patients today who we see on a regular basis who have different comorbidities, a different BMI, and each recommendation that you've given me has been individualized. Like, for example, the first patient who may not necessarily had any comorbidities, you were going to look for their overall health and make some lifestyle modifications. And then with this patient, you talked to me about, GLP-1 therapy and
It is
educating on bariatric surgery. So
absolutely, it is a very interesting field. And as you know, we've talked about it earlier. I'm a trained family medicine physician, and I've been in primary care practice for quite a while. And what I have seen is that a lot of the comorbidities that I have treated, the root cause is obesity. And so coming from that place of frustration of like, how can I actually help my patients? And that's how the interest in obesity medicine have grown. And then, I sought training and I sought certification for it. And then I'm here. So I'm happy to be able to provide this program. We started it, the medical weight loss, we started it in 2022, and it has grown now to myself. We have 4 other obesity medicine certified physicians in our practice that come help out, another full-time physician, and then 3 other that comes on certain days. So we are able to accommodate more of your referrals.
yes,
So,
absolutely.
Yeah, they absolutely send them to us. It is very nuanced, and of course, our primary care physicians, providers can manage obesity. But what we can bring is this multidiscipline approach. If you would allow us to take care of your patients, this is what we can provide for sure.
Well, we have been very appreciative, and I know our patients, when they come back, they're always very thankful for the education that they receive and the hands that you are able to get them into. So thank you for that. So just kind of wrapping things up, I always ask our guests, if you had a few takeaways today, what would be important things that you want us to leave here with? That's a loaded question, right?
All right. So I think for, in general, for obesity care or for obesity medicine and taking care of our patients with obesity is that recognizing that it is a disease process, okay?
Mm-hmm.
It is a chronic, relapsing, multifactorial medical condition. And so if a patient might have been blaming themselves for why they're at this weight, I want to be able to, us as medical providers, we want to try to be able to take away the blame and really neutralize obesity as any other chronic disease like diabetes, hypertension. Because a lot of the times, and I'm sorry, I'm gonna be like in my soapbox or whatever you call it.
No, please. This is why we have you here.
Yeah. So a lot of the times, our patients suffering from obesity, they have been traumatized by the medical care. You know, like the medical care that they have received. They are blamed for their weight. They have been called lazy or unmotivated, and the opposite is, it's true, you know. They have tried several times, like multiple times, of trying to lose weight over and over again, and they're not succeeding just because there are barriers. There are psychological barriers, there are metabolic barriers, and
You mentioned genetic earlier, and I hadn't even thought about that.
even genetic predisposition. So we want to try to be able to look at the patient just like any other patient, right? And treat them with a lot of compassion. They are humans like any other patients, and so we want to try to be able to bring them in and treat them as any other patient. Okay.
Absolutely.
Because like when we, as medical providers, because like they receive a lot of like stigma.
Absolutely. Yeah.
And when they do, they stop coming.
Yes.
They stop coming, and if they feel like they have been stigmatized by the medical care, then they don't come to your primary care office, and they miss their primary what am I trying to say?
Their follow-up appointment, like their PCP appointment.
Their health maintenance.
Yes.
There are data that our patients who suffer from obesity actually do not go get their mammograms.
Oh, wow. What I'm hearing too, like you say, is like being a good human and just being compassionate, and treating, not necessarily, you're treating obesity, but you're treating the person. You're trying to figure out like what's going on, and kind of forming a partnership. And if they are, if they feel accepted by you and feel like you are actually caring for them, they're more likely to probably show up to your appointment.
They are more likely to show up to your appointment.
Show up to their health maintenance.
And they will be more engaged in their own care when they know that.
It's kind of like that buy-in. Yes. Getting that buy-in.
Yeah, that is a great word, buy-in into their health. Yeah, so I guess that would be, and then one other message would be meeting the patients where they're at. We know that recommended physical activity is 150 active minutes.
Yeah. Yeah.
You have to go exercise 30 minutes a day, right?
Yeah.
If they are at higher BMI, like our patients here, BMI 45, and they have osteoarthritis, that would be so difficult for them.
It's difficult for me, yeah.
To expect 150 active minutes on their feet. So really utilizing again motivational interviewing. Like what could you do? It could be like 5 minutes of arm circles.
Yeah. Absolutely.
Or upper body exercise.
So moving in general.
Yes. So how do we encourage movement? And rather than using exercise, we might just use the word like how are we going to move our body today? So like how would you like to have a how would you like to move your body?
That has such a different connotation. I feel like hey, I'm just going to move a little bit today instead of exercise. that word exercise, there's something about it. I feel like maybe that's just me, but
no, it's just not you. It's
Yeah.
actually one of the things that we learn, like in our curriculum is like when you actually change the language, certainly in certain things, that it can be more welcoming.
that's interesting,
You can
huh?
actually invite more buy-in.
Yes.
Like your word, into their care, like I said, like we have talked about earlier. Yeah.
So meeting patients where they're at on an individualized approach, and then just looking at obesity as like this chronic condition, just like asthma or diabetes or coronary disease. So wow, that's phenomenal. So I just wanted to thank you again, Dr. Famularcano. Where are you guys located, and what does the referral process look like for you guys?
Thank you for that chance to promote our office. We are CAMC Medical Weight Loss Center, and we are located at 600 Tracy Way, but Northgate.
Northgate.
Yes.
Okay.
And our phone number is 304-388-4965. If someone would like to find more information, so that's our phone number, 304-388-4965. And of course, within the CAMC Vandalia Health referral system, you should be able to do those internal referrals as well.
Absolutely. I've sent many.
Yes, thank you so much. Yes, yeah, I remember that trucker patient that you have actually. Yes, So it has been my pleasure. Thank you for inviting me to this podcast.
Well, we are so thankful to have you. You guys heard it here. This has been Dr. Famularcano joining us today, providing her expertise in obesity medicine. As always, I hope this episode helps you feel more equipped in your practice to manage these complex cases and to know when to collaborate with specialists to get the best care for your patients. Thank you for tuning in, and we'll see you next time on Health Matters, where we continue exploring the intersection of primary care and specialty medicine. Until then, thank you for joining me on this journey toward better health.
Health Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Sheylan Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.